So, skiing injuries, uncharacteristic ligament damage. 11. History of backache, radiograph of the lumbar spine shows diffuse bone sclerosis. MRI shows diffuse low signal intensity of bone marrow on all sequences with no architectural distortion. MRI shows splenomegaly, but most likely with myelofibrosis. Myelofibrosis shows on MRI low signal of bone marrow all sequences, and then is benign, so no architectural distortion, and also shows splenomegaly. So on, okay, so next, it shows backache and number 5 shows diffuse bone sclerosis. So diagnosed myelofibrosis. Number 20, known case of rheumatoid arthritis. MI shows symmetrical disease in both hands with areas of high signal on T2 and low signal on T1 around the triangular fibrocardioid complex (TFCC). Then the radiocarpal joint and the distal ulnar joint. So there's areas of high signal on T1, T2 and low signal on T1 in the TFC triangular fibrocardiac complex, the radiocarpal joint, and the distal ulnar joint. Then abnormal areas at the TFCC and RCJ, triangular fibrocardiac complex, and radiocarpal joint enhance following administration of gadolinium, but the distal ulnar joint does not enhance following gadolinium. What the finding indicates? Indicates that hypervascular pannus at the triangular fibrocardiac complex and radioulnar joint, proximal joint, but there's joint effusion at distal radioulnar joint. So there is no enhancement of the gadolinium in the distal radioulnar joint. Question number 13. The enhancement following gadolinium in TFCG and RCJ, so there's hypervascular panels. It shows hypervascularity in TFCG and RCJ, but no enhancement in DRUJ, so it is only DRUJ that's not hypervascular, it's only joint effusion. Question number 13. MRI shows serpiginous shaped lesion in the distal radial right tibia. A parallel rim of hypo and hyperintensity is seen on one of the imaging sequences, which is very helpful in confirming that the lesion is secondary to metaphyseal typized osteonecrosis rather than neoplasm. Which image sequence is this parallel rim most likely to be seen? Fast spin echo T2WI. Correct? To differentiate between osteonecrosis rather than neoplasm, the MI sequence required is fast spin echo T2WI. Question 14. Which would more suggest a malignant rather than benign cause for a reversible complex fracture? A convex bulge involving the whole body of the posterior cortex of the vertebral body shows malignant rather than a benign cause for reversible complex fracture. Convex bulge in the whole of the posterior cortex of the vertebral body shows malignant disease. Question number 15. A radial head fracture noted. What is the most common fracture with this injury? Coronary pulse of fracture. Now, with the radial head fracture is associated with coronary pulse fracture. Question number 16. History of flushing, pruritus, and diarrhea by studies of irregular diffuse thickening of small bowel pores. Reveal elevated serum tryptase level, most likely diagnosed mastocytosis. Remember that elevated serum tryptase level is seen in mastocytosis. Then the history of flushing, pruritus, and diarrhea. These are signs and symptoms of mastocytosis. And then also thickening of small bowel pores. So its diagnosis is mastocytosis. Question 17. Widening of the distal femur metaphyseal with widened intracondyle notch bilaterally. G sequences of Grimm artifact by is hemophilia. Now the hemophilia again it shows widened intercondylar notch. Widened intercondylar notch of the knee joint is seen in hemophilia. 18. Cemented right total hip replacement. Progressive vertically linear rounded focal area of Byzantium at the cement bone interface adjacent to the tip of the femoral stem. Which given reasons is the most appropriate for this progressive deficiency? Aggressive granulomatous disease. Look, she already underwent right total hip replacement. Then there's progressive linear rounded focal deficiency at the cement bone interface. So what does this progress show? It shows aggressive granulomatous disease. 19. RTA shows head-on collision. Then pain in both knees. Which finding am I most likely? Bruising at the anterior aspect of the tibia. In RTA, after RTA, pain in knees, then MRI will show bruising at the anterior part of the tibia. Question 20. Most common fracture bone RTA is tibial. 20. RTA suspected in brachial flexion injury. Which finding is most suggestive of nerve root avulsion? Pseudomeningeal seal. Pseudomeningeal seal shows nerve root avulsion after RTA. Question 21. Baker's cyst communicating of this cyst with fluid at the posterior aspect of the knee joint between which two tendons, lateral head of gastrocnemius and semimembranosus. A Baker cyst is seen is between which two tendons, lateral head of gastrocnemius and semimembranosus. Question 22. Patient has palmoplantar pustulosis, accidental sclerosis of the manubrium, and erosive disease in the sternoclavicular joint. Exhibits a loosened lesion in the proximal tibial metaphyseal with associated paracetal reaction. Most likely diagnosis: SAPO syndrome, synovitis, acne, pustulosis, hyperostosis, and osteitis. SAPO syndrome. They tell you in the MCQ that he has pustulosis. So SAPO, P stands for pustulosis. So then other synovitis and so osteitis syndrome. So these are all, but important thing is pustulosis is only seen in SAPO syndrome. Then 23. A centimeter diameter well-defined dorsal C. I think 3 centimeter diameter will be. Question number 23. Most likely it will be 3 centimeter diameter. 3 centimeter diameter well-defined loosened bony lesion with a thin sclerotic margin as identified within approximately 5 of the tibia. No joint classification more likely for the diagnosis for the abnormality is chondroblastoma because thin sclerotic lesion in the proximal epiphysis of tibia and epiphyseal lesion and then the thin sclerosis margin, so chondroblastoma diagnosis. Question number 24. 75-year-old man with bone pain revealed anemia, renal impairment, hypercalcemia, proteinuria, and a monoclonal gammopathy. So what is most correct in relation to the radiological period of the disease process? Multiple myeloma is diagnosed, so most correct is 75% of patients will have positive radiographic finding on pain film. So in multiple myeloma, most true is 75% of patients will have positive radiographic finding on pain film. For which type of penetrating foreign body is ultrasound most superior for detection? What can be seen on ultrasound? 26. Female runner with pain in the leg on running. Histo bone scan to subtle, longitudinal, linear uptake on the distal bone scan images was diagnosed shin splints. A female runner, she's runner, so and then there's on bone scan there's longitudinal linear uptake on delayed bone images was diagnosed shin splints. Question number 27. Moderate severe osteoarthritis diagnosis. Which statement best describes the relationship between symptoms, pain film finding, and MRI finding? The MRI finding correlates well with the severity of disease on pain film radiography. In osteoarthritis, the MRI findings correlate well with the radiographic findings. Question 28. X-rays of well-defined reducing lesion with faint sclerotic margin in the mid-calcaneus. And whenever I talk about calcaneal lesions, the most likely they want to tell you about the calcaneal lipoma. So some central calcaneal within the lesion seen, most likely diagnosed Narcissus lipoma. The reducing lesion in the calcaneum, lipoma. The reducing lesion in the calcaneum is lipoma. 29. Painful knee. X-ray loosened area with a wide zone of transition in the distal femur metaphysis. The mitral fluid level most likely diagnosed is osteosarcoma. Now, again, the fluid level is seen in giant cell tumor and aneurysmal bone cyst and osteosarcoma. So, 25. Painful knee, loosened area with a wide zone of transition in the distal femur metaphysis. And a mitral fluid level most likely diagnosed osteosarcoma. Number 29. Let's see the other options. The telangiectatic variety of osteosarcoma does show fluid levels, as is malignant fibrosing sarcoma or any other necrotic when tumor telangiectasis. Osteosarcoma is highly vascular and contains necrotic blood. So, this telangiectatic osteosarcoma which has a high fluid level. You have to recognize it by the loosened area with wide zone of transition, so it's aggressive lesion, and then it has fluid level, so diagnose osteosarcoma. 30 bit adrenal radiographic finding is in keeping with the Hill-Sachs deformity, posterior humeral head indentation. The Sachs deformity shows posterior humeral head indentation.